Good evening, everyone. My name is Gina Makwabe. I'm the consultant physician and nephrologist working with Africa Healthcare Network in Tanzania to welcome you all for today's exciting topic, which will be presented by a very distinguished professor. And therefore, I would like to welcome you all. So during the session, we'll require you to actually to answer some of the questions will be popping up on your screen, so that it's kind of a survey. It will be popping up during the middle of the session, so that at the end of the day you will know who have joined, so that you can get your CPDs. This session, for those who are coming from Tanzania, will be subjected to the CPDs, and therefore if you want CPD, please make sure that you fill in that survey. So today's topic is the challenges of hyponatremia, and it's a great honor and pleasure to welcome Professor Nicolaos Madias, who is the chair, Department of Medicine, Caritas St. Elizabeth Medical Center, and the Chief Academic Officer, Caritas Christ Healthcare System. Maurice S. Segal, MD, Professor of Medicine, Tufts University School of Medicine, and a former co-chair of the Nephrology Forum of Kidney International, the official journal of the International Society of Nephrology. Professor Madias is the author of 65 original publications and over 100 reviews, book chapters, and books. Professor Madias, it's a great honor to welcome you. You're welcome, and we are ready to listen from you. Karibu.
Thank you very much, Agina. Thank you for inviting me back. It's a great pleasure to join you. I have no disclosures. I will start with a presentation of a case that was presented to me during a visiting professorship, and I'm doing this to create a context for the discussion of management of hyponatremia, where I will focus my remarks. I will get back to the case at the end of the presentation. A 52-year-old man was brought to the ED by ambulance with confusion, unsteadiness, and falls over the previous 2 days. Past medical history included hypertension, osteoarthritis, and alcohol abuse. His medications were metoprolol, valsartan, and hydrochlorothiazide. Hydrocodone acetaminophen had been prescribed 2 weeks prior for back pain. He was an architect, but had not worked the preceding 3 days. His wife described him as unsteady and weak, and she had witnessed several falls, but no seizures or incontinence. He had 3 drinks the previous evening. He received 1 liter of isotonic saline in the ambulance. On exam at the ED, BP was 110/70, pulse 90, respirations 15, temperature 37, oxygen saturation 98%, and weight 68 kilos. He had bruises over his torso and upper extremities. He was in mild distress, anxious, oriented to name and place, but not to date, and able to converse in a slow and somewhat tangential manner. He had no motor or sensory deficits. Initial tests showed a sodium of 101, a potassium of 2.5, chloride of 63, total CO2 of 30, BUN 8, creatinine 0.6, CK 1530, troponin negative, AST 225, ALT 125, calcium 8.5, albumin 4.2, white blood cells 9,500, and hemoglobin 12.5, and undetectable ethanol. ECG, chest X-ray, and head CT were unremarkable. So this is to create a context for our discussion. We'll get back at the end, but I will invite some thoughts about the type of hyponatremia that our patient has and the plan for management. Thank you. So when I contemplate managing hyponatremia, I ask 3 critical questions. I want to know which of the determinants of the serum sodium concentration are deranged and what is the underlying culprit. I want to know how urgent is the need for intervention. Do I have to act in an emergency fashion, or I can do it over, hours. And what is the specific therapy should be instituted, and which are the associated pitfalls? 3 critical questions. We'll address the first one, and the seminal Edelman equation tells us that the serum sodium is approximated by the ratio of the exchangeable, namely the osmotically active sodium and potassium content in the body divided by total body water. So cationic solute divided by total body water. Immediately, we can discern that the sodium is determined by an excess of water relative to the cationic content in the body. Now, there are various types of hyponatremia, but by far the most common form is the hypotonic or dilutional hyponatremia that is caused by water retention, thus establishing an excess of water relative to the existing sodium and potassium stores. Now, water retention most commonly reflects impaired capacity of renal excretion of electrolyte-free water, what we call aquaresis, namely water without electrolytes. So the retention of water is secondary to decreased capacity of renal excretion of water, but it has to be coupled with electrolyte-free water intake in amounts that exceed this capacity. This is a fine but very important point. Imagine an elderly woman with severe congestive heart failure at home who ingests a diet of 600 milliosmoles, and because of her heart failure, she has a urine excreting defect, and she cannot dilute her urine below 600 milliosmoles per kilogram. So 600 milliosmoles the diet, 600 milliosmoles per kilo is the limit of dilution in the urine. You can imagine that as long as she drinks 1 liter plus for the additional losses, insensitive losses, she will be fine. But if she starts drinking 1.5 liters and 2 liters, she will express hyponatremia. So she has the baseline water excreting defect, but she will not express it until she couples that with a water intake that exceeds her capacity, even if that is impaired. Now, less commonly, the water retention is not due to impaired capacity of renal excretion, but is caused by excessive water intake that overwhelms a normal or nearly normal capacity of aquaresis. So I have a normal capacity of aquaresis, but I overwhelm it by drinking a lot, as in psychogenic polydipsia. But this is much rarer. Now, this in the middle shows the Edelman equation and allows us to look at the possible changes in each 3 parameters. The sodium in hypotonic hyponatremia can be decreased, as in hypovolemic hyponatremia. It can be normal, as in euvolemic hyponatremia. It can be increased, as in hypervolemic hyponatremia. So hyponatremia is very well known, is not a marker of sodium stores, for it can be associated with decreased, normal, or increased sodium stores. It's a problem of water homeostasis. Potassium can be decreased, as it is usually in cases of hypovolemic and hypervolemic hyponatremia most of the time, or normal, as it is in euvolemic hyponatremia. And water can be all over the place. It can be decreased and hypovolemic hyponatremia, normal because you develop, you lost volume, but you drank enough to normalize your total body water, or increased, as it is in a euvolemic hyponatremia or hypervolemic hyponatremia. So all sorts of combinations, but the important point to keep in mind is that total body water has to be in excess of the prevailing sodium and potassium stores. Now, this is the classical diagnostic algorithm to hyponatremia, which gives primacy to a clinical assessment of volume status into hypovolemic, euvolemic, and hypervolemic categories, and then makes use of urine sodium greater than 20 to 30 or less than 10, so that it defines the hypovolemic into renal losses and extrarenal loss categories. In the euvolemic state, where urine sodium is expected to be more than 20 or so, and the hypervolemic disorders, where in the states of volume retention, like cardiac failure, cirrhosis, nephrotic syndrome, absent of effectiveness of diuretics, the urine sodium is vanishingly low, as opposed to conditions of acute or chronic renal failure, where it is increased. Now, the syndrome of inappropriate antidiuresis, which is by far the most common cause of euvolemic hyponatremia, as you know, has myriad causes, a number of cancers, including pulmonary, but several others, other pulmonary conditions, including an acute respiratory failure and positive pressure ventilation, a number of CNS disorders in addition to central tumors, an ever-increasing list of drugs, including prostaglandin synthase inhibitors, tricyclics, serotonin reuptake inhibitors, opiates, and the like, and miscellaneous other causes like the postoperative state, pain, severe nausea, and exercise-associated hyponatremia, and also idiopathic causes, because we don't really recognize the link with the serum, with the state of inappropriate antidiuresis. I should state that an increasing number of elderly have the SIADH, and in 50% of those, the cause actually is idiopathic, undescribed. Now, in the diagnosis, of course, we focus on, in the diagnostic workup, we focus on predisposing conditions, acute or chronic diseases, fluid electrolyte intake losses, changes in body weight, the various medications, previous history of hyponatremia, a sense of how much protein the patient takes, and also the symptoms of hyponatremia. Physical examination, as I already said, we focus on a clinical assessment of ECF volume, signs of predisposing condition, volume depletion, congestive heart failure, cirrhosis, signs of hyponatremia, and then the usual initial ancillary test of a panel of electrolytes, the billion creatinine, uric acid osmolality, cortisol thyroid panel, and a focus on urinary electrolytes output, urine over serum electrolyte ratio that we value very, very much. And in this slide, I try to show that examining the urine sodium plus potassium content and relating it to sodium in the serum can give you very valuable information of what is happening with the urine in terms of the prevailing hypotonic state. So if the sodium and K in the urine matches the serum sodium, their ratio is 1, and there is no impact on the prevailing serum sodium. The other two columns show what would be the impact of 1 liter of urine loss on a 70 kilo or a 50 kilo woman. And in this case, it will be none, because the sodium and K in the urine are identical in essence to the serum sodium. If the serum and K in the urine are greater, larger than the serum sodium, the urine is hypertonic as opposed to the serum, and thus it contributes to a further lowering in the serum sodium concentration. And you can see the impact of a liter of such a urine loss on the serum concentration or sodium concentration. In a 50 kilo woman, it will decrease it by 2.5. If the sodium and K is half of that in the serum, the urine is half isotonic to plasma, so that in actuality it helps correct the hyponatremia. And you can see by how much amount. This is what in theory happens when we give furosemide. We make the urine half isotonic to the serum, and thus we contribute to the correction of hyponatremia. If the urine electrolytes are very low, here 20 compared to the serum 120. Obviously, this will have a major effect on correcting hyponatremia. This happens when we will withhold water in somebody with primary polydipsia. Please note that a liter of such urine will increase the serum sodium by 4.2, a very substantial amount, which should be kept in mind. Now, the symptoms vary, and here are classified as mild and moderate and severe. Mild being relatively non-specific, anorexia, nausea, weakness, some headache, some muscle cramps, proceeding to moderate with hyporeflexia, ataxia, restlessness, confusion, hallucinations, and severe stupor with urinary and fecal incontinence, generalized seizures, coma. One can develop non-cardiogenic pulmonary edema, brainstem herniation, respiratory arrest, which can lead to permanent brain damage or death. Now, the symptoms are more severe. The biggest the magnitude of the hyponatremia relates to the rapidity with which hyponatremia develops. Much more severe symptoms if the hyponatremia is severe and developed rapidly, and how long the hyponatremia has been around. Much worse if the hyponatremia is acute, much better if it is chronic. And we define acute and chronic arbitrarily by 48 hours, which is a time limit that presumably matches how long the brain requires for so-called brain volume adaptation. Now, this is taken from a prior publication of ours, and if you develop hyponatremia, the hypotonicity is, of course, reflected into the brain, and depending obviously on its magnitude, one develops cerebral edema. Immediately, as you develop this increased pressure in the brain, CSF goes into the spinal subarachnoid space, and a little bit the pressure is ameliorated. But after that, to the extent that hyponatremia and hypotonicity prevails, any increase in the brain edema because of the rigidity of the cranium is translated into big increases in intracranial pressure. Thankfully, there is a rapid adaptation that is initiated within minutes, and initially deals with extrusion of sodium potassium chloride and water from brain cells, which is then accompanied after hours with loss also of some organic substances of the brain, which we call osmolytes, like taurine, minoxidil, creatine, and others. And the combination of these electrolytes and osmolytes coupled with loss of water reestablishes the brain volume, such that in this situation we have somebody with a sodium of 135, normal, and somebody who has had a sodium of 97 for several days, and the neuroradiologist cannot tell the difference. The volume of the brain has been reconstituted. You can see the cavities of the brain, the ventricles, you can see the sulci, as opposed to the acute situation where you could not really differentiate. You could not look at, I'm trying to go to this one. You can see that the ventricles are obliterated acutely. The sulci cannot be shown, as opposed to the chronic situation where they reemerge. And as I said, the neuroradiologist cannot tell the difference. Now, if you are in this situation of full adaptation, brain volume is normalized, but the brain is not normal. There is continued hypotonicity, and there is continued loss of electrolytes and osmolytes. In this circumstance, if you correct quickly by imposing a hypertonic gradient, there is a chance for developing a grave situation called osmotic demyelination, as opposed to when you correct slowly and allow the reconstitution of the brain cell and the reemergence of the electrolytes and osmolytes, where you reestablish a normal brain. Now, this is some features of the osmotic demyelination. which overwhelmingly is an iatrogenic complication developing 1 to 7 days after overcorrection of hyponatremia that has undergone substantial brain adaptation. The possibility of somebody with acute hyponatremia developing osmotic demyelination after overcorrection is extremely low, but it can be high, considerable, when you do that on a brain that has undergone brain volume adaptation. It is independent of the correction method. It can happen just by water restricting someone. You don't have to give hypertonic saline or other solutions and so on. It can happen just by observing somebody who is water restricted. Most cases occur when correction of somebody with a brain that has undergone substantial brain adaptation, it exceeds 12 milliequivalents per day, usually. It can be 14, 15, 18, 17, whatever. But there are occasional well-documented cases after only 9 to 10 milliequivalents per liter, and I have seen some of those. What happens is brain shrinkage triggers the demyelination of pontine and extrapontine neurons that can then cause neurologic dysfunction with the classical situation of ODS, hyperreflexia, quadriplegia, pseudopearl palsy, Parkinsonism, the locked-in syndrome, seizures, coma, and even death. Importantly, 2 or more weeks from initial neurologic manifestation might elapse before you can document the diagnosis by imaging. The syndrome has a dismal prognosis most of the time. Prevention is vital. And there are some risk factors that have been identified for the ODS syndrome: severe chronic hyponatremia, especially with a serum sodium less than 110. Severe chronic hyponatremia less than 110. Chronic alcoholism, hepatic failure, orthotopic liver transplantation as the serum sodium increases rapidly on somebody with a chronic decreased sodium, potassium depletion and malnutrition, and the potential mechanism is not fully understood, although most people think now that there's disruption of the blood-brain barrier. Now, these are situations where severe symptomatic hyponatremia occurs in a severe psychogenic polydipsia, a postoperative state, endurance exercise, use of ecstasy, induction of delivery with oxytocin, and unthinkable water drinking contests that have led even to deaths of participants, an amazing lack of wisdom of the organizers. But most important, I want to emphasize that in chronic hyponatremia, as I already said, the brain is not normal. It lacks electrolytes and osmolytes into the cells. The state is not asymptomatic. Actually, careful reviews of patients with chronic hyponatremia show a variety of symptoms: nausea, you can have some headache, you can have an occasional vomiting. Studies in elderly showed cognitive deficits, ataxia, gait disturbances, and a propensity to falls and fractures, an amazingly increased tendency for these symptoms compared to normonatremic counterparts. And when extreme, usually less than 110, actually chronic hyponatremia can manifest confusion, delirium, and rarely seizures, but not the other life-threatening complications of severe acute hyponatremia. No coma, no non-cardiogenic pulmonary edema, no brainstem herniation, and so on. Now, some people want to differentiate hyponatremia clinically into acute versus chronic, and I think this is a very poor decision, mostly because you very rarely know that the hyponatremia is really acute. You can know that on somebody, for example, who developed postoperative hyponatremia to the extent that you had baseline electrolytes, and you know that an operation took place after that yesterday, and now I'm seeing the patient, and I can say that the time frame is several hours. I call that acute, less than 48 hours. But absent that, you can't really tell. For example, you have a marathoner who presents with hyponatremia. There is no evidence that the patient didn't have mild or moderate chronic hyponatremia before they started the marathon and the like. You have somebody who took ecstasy. We don't know if they don't have chronic hyponatremia. Overwhelmingly, chronic hyponatremia is the most common syndrome. And please keep in mind that acute hyponatremia can have also substantial brain volume adaptation. Suppose you see somebody 36 hours after hyponatremia ensued. Studies in animals show that brain volume adaptation is nearly complete. Or think of somebody who has chronic hyponatremia and now has developed an acute on chronic element. So my admonition is that absent direct knowledge, it's better to assume that the hyponatremia is chronic. I prefer to differentiate hyponatremia into severely symptomatic versus oligo and moderately symptomatic, because this has an impact on how I will manage the patient. And I define severely symptomatic the way I defined it in a previous slide. Now, how urgent is the need for intervention? Do I have to correct the hyponatremia urgently, or I can take hours and days? I consider an indication for urgent correction patients who have severely symptomatic hyponatremia. This is unrelated to the duration of hyponatremia. I don't interject here duration. I say that patients with severely symptomatic hyponatremia, as I define them, should be treated urgently. And I also include patients with hyponatremia in association with neurologic or neurosurgical diseases, pre-existing. Think of somebody with brain trauma or somebody with a brain hemorrhage. They already have a measure of cerebral edema. And any hypotonic hyponatremia superimposed on that can have grave consequences. And I always like to address that urgently. So severely symptomatic hyponatremia or hyponatremia associated with pre-existing neurologic or neurosurgical disease. And what specific therapy I should institute and which are the pitfalls? Well, in severely symptomatic hyponatremia, the available guidelines, and now there is an American guideline and there is a European guideline, both of them say urgent increase of serum sodium by 4 to 6 milliequivalents per liter is sufficient to control a hyponatremic emergency. And this is based on studies in animals and some good observations in humans. Even somebody seizing actively, if you increase the sodium by 4 to 6, overwhelmingly, the seizures will stop. Somebody who's herniating has been shown that they will reverse the herniation. Now, there is a controversy about bolus versus continuous infusion. Both guidelines suggest boluses, and this came from experience in exercise-associated hyponatremia, where people have given in the field to triathlon or marathoners 100 mLs or 150 mLs of 3% sodium chloride over 10 to 15 minutes intravenously, and they have repeated several times, 2 to 3 times, until they get correction. Obviously, you understand that to do that, you require probably an hour or so. You give it over 20 minutes, over 10 minutes, you measure, you give it another, and so on. And Dr. Lloyd and I have objected to this one size fits all, because if you do the calculations, you will find that given 150 mLs of hypertonic sodium in a 50-kilogram woman, as opposed to a 100-kilogram man, will create very substantial difference in sodium concentration, much larger in the woman as opposed to the man. So we have always thought that a quantitative approach in using such a medication, such an impactful medication, makes sense. Why give the same amount to everyone and not quantitate how much I need to make this 4 to 6 milliequivalent per liter correction? I will get back to that. And the recommendation is, by guidelines, not to exceed 10 milliequivalents per liter in the first 24 hours and 18 in the first 48 hours, but 8 milliequivalents in any 24-hour period for somebody who has risk factors for ODS. We have objected to that as well. We, meaning Dr. Lloyd and I, in the sense that our experience is that it happens in clinic that the limit, the threshold that you put is frequently exceeded. So it's very common to overshoot the mark. You say, oh, I don't want to exceed 10, and here you are at 14. So we have thought that because it doesn't offer any advantage after you achieve the 4 to 6 acutely, quickly, to really deal with severe symptomatology, our limit is set at 8 for people who have no risk factors for ODS in any 24-hour period, and 6 for those that have high risk factors for ODS. Understanding again that you have a limit of 8, you can frequently be at 10 and 11 and so on. But we thought that it's better to be conservative, given the fact that there is no benefit realized to go more than 6 or so. You have to give furosemide to those that you are concerned about volume overload when you give the hypertonic. Of course, you withhold water and offending drugs. You do not use Vaptans even if they are available. For seizing patients, you provide anticonvulsant therapy, laryngeal intubation, oxygen administration, and ventilator support if needed. You do frequent monitoring when you use hypertonic, by this meaning at least every couple of hours, and you are vigilant for overly rapid correction as it relates to the limits that I have set. And if overcorrection occurs, you lower the sodium using hypotonic fluids and DDAVP. We have introduced this formula, the infusate formula, for calculating how much hypertonic sodium you need to produce a certain change in sodium serum, and this of course can be applied for any fluid. Here is the sodium concentration, sodium and K concentration of hypertonic sodium is 513, and here is the effect on sodium per 1 liter in a 60 kilogram woman with a sodium of 110 to start with. And it contrasts with normal sodium, which has a sodium concentration of 154, with normal sodium and 30 milliequivalents of potassium chloride, where the sodium NK is 184, and then Ringer's lactate. Obviously, hypotonic fluids will tend to decrease the serum sodium concentration. And here's an example in a woman, 31-year-old woman with post-appendectomy SIAD, postoperative day 2. She underwent 3 grand mal seizures and she's stuporous, responsive to pain but not to commands. She's euvolemic clinically with weight of 46 kilos. Her sodium is 112, her serum osmolality is 228, her urine osmolality is 510. We give her diazepam, phenytoin, we laryngeally intubate her and start mechanical ventilation. Withhold water, we decide to administer 3% sodium chloride. We infuse 20 milligrams of IV furosemide. We estimate her total body water as 0.5 times her weight at 23 liters, and we set as a goal to increase sodium by 4 millimoles per liter in an hour. We apply the equation. Sodium of the infusate is 513. The sodium of the patient is 112. Her total body water is 23 plus 1 liter of the hypertonic sodium. It says that per liter of hypertonic sodium, the sodium concentration will increase by 6.7 milliequivalents per liter. To achieve a goal of 4, I need to give 4 divided by 16.7, 0.24 liters or 240 mLs per hour. I do that, and 1 hour later, her serum sodium is 116 from 112, or a delta of 4. Now I say I want to increase it by 1 milliequivalent per liter in the following hour and calculate with the formula that if I give 60 mL per hour, I will achieve that. 2 hours later, the sodium is 117, a delta of 5. No more seizures have occurred. The patient is lethargic, but responds slowly to simple commands. Now I say, let me increase by 0.5 per hour, and I give 30 mL per hour of that. 3 hours later, her sodium is 119, which is 6 hours from onset of treatment. She has a delta of 7. The patient is somnolent but responds promptly to simple commands. I declare that I have enough correction for the day. Hypertonic saline infusion discontinued. I continue to water restrict the patient, and I continue to observe her with continued monitoring of her serum sodium. Strangely, some investigators have commented aggressively against the use of the formula on the basis of various grounds. The validity of the formula has been documented in patients who are under diuretic, who have a water excreting defect. Of course, if you have somebody who is volume depleted and you give them volume, and after 3-4 hours they start having a diuresis, the formula will not be valid because it is based on assuming that the patient is more or less a closed box, that they don't realize any other losses or gains of fluids and electrolytes other than the infusate. However, and that's why it has been validated and has shown excellent efficacy. Now, if you have somebody who starts having a diuretic phase, obviously they don't need to be treated with hypertonic saline at that time. You need to observe what's happening in the urine, and we have developed a variation of our formula, small variation. We put the serum sodium in the front. We subtract the sodium and K concentration of the fluid you are losing, urine or elsewhere, and from total body weight, we subtract a liter of the fluid in question. And if you use that, you will find very well, you can calculate what will be the impact of a liter of fluid that you are losing as opposed to giving on the serum sodium concentration. Here we have an aquaresis with a sodium K of 20 milliequivalents per liter. Per liter in a woman of 60 kilo as defined, it will increase her sodium by 3.1 liters. And this has to be factored if you are reflecting on what your treatment will do to the patient if she has this output. And this can be true for any output that's going on. Now, what about patients who are not severely symptomatic? We impose a water restriction to below the level of water losses. If the patient is hypovolemic, we replete with sodium chloride. When the patient has hyponatremia because of a presumed offending drug, we discontinue that. When the patient is suspected to have an adrenal insufficiency hypothyroidism and we do appropriate tests and we define it, we give back the missing hormone. It's very important to keep in mind that these are all situations where you have to have vigilance about the possibility of the patient getting rid of their water excreting defect by applying these maneuvers, and you have now to watch the urine for dilution and so-called autocorrection, which you have to compensate for. So repair of hypovolemia, discontinuation of thiazides or any other medication that is creating the SIAD, or cortisol or thyroxine replacement in a patient who is having hypocortisolism or severe hypothyroidism can give rise to such severe aquaresis. Keep in mind that potassium repletion is equivalent to sodium repletion. Potassium repletion is equivalent to sodium repletion in patients as defined by the Edelman equation. Given 1 milliequivalent of potassium impacts the serum sodium equivalently to giving 1 milliequivalent of sodium. And this is crucial because many times physicians give both treatment for sodium and the potassium, but disregard the impact of potassium on the serum sodium. And then you have to keep in mind the 6 to 8 milliequivalents in any 24 hours. 6 milliequivalents in any 24-hour period should not be exceeded for people with the risk factors for ODS that I described. Tremendous vigilance for overly rapid correction, and then case-specific measures, optimizing hemodynamics in heart failure, administration of loop but not thiazide diuretics, increasing solute excretion, which will impose loss of water, like sodium in the diet, urea, and protein. A lot of work has been done with the utility of urea now as a medication for the SIAD, for heart failure, for patients with nephrogenic SIAD. The treatment has not caught up in the United States because of bad taste, but I have used it extensively over the last many years. You know, adding the urea into some juice or jelly makes it quite palatable. I have tasted it on several occasions and it's really acceptable. And I think it's a major development that Dr. Decau's group from Belgium has offered to us. And then the V2 receptor antagonists that have been approved by the FDA in the United States for the treatment of SIAD and heart failure associated hyponatremia. In Europe, the European Medicine Association has approved it for treatment of SIAD, an expensive treatment, unfortunately, and one that is not really used as much as it deserves to be used because it's such a physiologic way of treating patients who have a water excreting defect by opposing this water excreting defect by antagonizing the binding of arginine vasopressin to its V2 receptor. Now, what about pitfalls to management? I consider a pitfall the non-quantitative approach that actually is espoused by many. You know, management of hyponatremia is not something like managing uremia. You know, we'll give you an antibiotic and we'll see you in the morning. It's a dynamic physiology and it requires a patient-specific approach, we believe. I think following what's happening in the urine is very important. Is the urine hypertonic? Is it dilute? Does the rate of urine flow has changed? And this again can be dynamic, and a lot of problems have been developed because we disregard the urine. Fluid restriction is not risk-free, and I try to impress on you that a liter of fluid restriction, a liter of aquaresis can have a major impact on the correction of serum sodium. 0.9% sodium chloride is not appropriate treatment for the syndrome of inappropriate antidiuresis, and for situations where we have a concentrated urine, we run the risk of really worsening the hyponatremia. Severe sodium restriction can be counterproductive in edematous patients because if you make it very severe, you increase the amount of free water that the patient takes, and you can actually see worsening of the hyponatremia. Potassium repletion should be really followed very, very closely in hypokalemic patients, keeping in mind that it has a similar effect to correction as sodium administration. Differentiation between hypovolemic hyponatremia and SIAD might not be clear-cut, and occasionally one might have to try an infusion of a liter or two of normal saline to see the difference by following what's happening in the urine and what's happening in serum sodium. And failure to monitor closely and reassessing the prescription for treatment is a major, major pitfall. As I indicated, in severe hyponatremia, I follow the sodium at least every couple of hours. In other situations, every few hours, depending on the situation. Now I would like to return to our case, and I would like to invite anyone who might want to bring some concepts about what we are dealing here. We have a 52-year-old man. It can be an opening to our discussion who comes with to the ED by ambulance, confused, unsteady, and with falls of the previous 2 days, had hypertension, osteoarthritis, and alcohol abuse, taken metoprolol, valsartan, hydrochlorothiazide, and hydrocodone and acetaminophen had been added 2 weeks prior. And his wife described him as unsteady and weak and falling, no seizures or incontinence, 3 drinks the previous night. He comes with these vital signs, and he's kind of oriented, ×2, no motor or sensory deficits, but mild distress, anxious, tangential manner, and has a sodium of 101, a K of 25, billion 8, creatinine 0.6, and the like, and the head C shows that it is unremarkable. Any general thoughts about the points that stand out and our direction for treatment? And then I would like to share with you the patient's course.
Anybody can come in, anybody can suggest.
Yes, anybody can make a suggestion.
Yeah,
How does the patient look to you? What do you think they're having? He's having.
Anybody. Yes, Dr. Mazhar, please go ahead. Unmute and talk.
So the time is relatively short, and this is my fault as usual. I have gone a little bit, I should have reserved more time, but the things that impress me are that this man has been having confusion, unsteadiness, and falls over the previous 2 days. And I not...
One thing is he's had a fall. So whether he's had a head injury is one thing. The other thing is hydrocodone, the drug, can also probably cause hyponatremia.
Of course.
And then, and the other thing is giving isotonic saline in certain situations with the sodium being so low can actually worsen the probably they're giving him a little more free water as well. They're using isotonic saline. So these are 3 things that I can think of. For any other drug, alcohol abuse, I'm not too sure of that, whether that produces anything. So these are 3 things that I can see very obvious there.
Very, very nice and on point. The physical exam did not show any injury to the head, and the head C was also unremarkable. It didn't show anything. But like you, I note the presence of drugs, hydrochlorothiazide and hydrocodone, that both can produce problems with water excretion. I also note that he's not described as volume depleted. He has a good blood pressure, and but has substantial symptomatology, and we know that he should be having seizures. Now, looking at a sodium of 101, it virtually excludes acute hyponatremia by itself.
Yes.
Because as you know, by this meaning hyponatremia that has not undergone substantial brain adaptation. Because if you were to drop the sodium, let's say, aggressively by fusing water with a tube and intravenous to drop it down to 101, the brain edema will be massive and the patient will expire long before the sodium drops to that. So by definition, the patient must have brain volume adaptation, and whether it is simple chronic hyponatremia or there is an acute element superimposed on severe chronic hyponatremia, I cannot tell, but what I can tell with confidence is that there is a very substantial brain volume adaptation, which is also corroborated, but I did not need to have it by head CT, which is unremarkable. I also note, so through that, I would say that the patient has for sure an element of chronic hyponatremia, if not completely. I will say that most probably hydrochlorothiazide, hydroxycodone, nausea, severe nausea, distress are all components of AVP release. So it's a syndrome of SIAD. The fact that the BUN and creatinine are normal more or less excludes substantial volume depletion, but doesn't exclude a liter or two of deficit. I don't know how well he was eating and so on and so on. But then I note the sodium of 101, which is of course very severely depressed. I note the potassium of 2.5. And then I say, you know, my major situation here is as follows. This is a patient with moderately severe symptomatology, according to my situation, the three questions that I asked. There is hypotonic hyponatremia. It does not appear that there is substantial sodium depletion. There is substantial volume depletion, there's substantial potassium depletion. Most probably I'm euvolemic, although I cannot discard a minor element of volume depletion, but looking at the BUN and the creatinine, it's fine. And then I note that the patient has major risk factors for ODS in the fact that he has what I consider chronic severe hyponatremia to sodium less than 110, 101. I see that the patient has potassium depletion. I see that the patient is a chronic alcoholic. They have some element of liver involvement. This could be alcoholic hepatitis, I guess. I don't think I can call that liver failure. And I cannot call him malnourished with this albumin of 4.2, but he has three solid factors of ODS. So for me, the situation becomes, make sure you treat the patient as a moderately severe hyponatremia, not an urgent correction, with laser focus on not exceeding 6 milliequivalents per liter in the first 24 hours. Make sure that you don't exceed 12 milliequivalents per liter in the first 48 hours, where ODS usually happens. The first and 24 hours are crucial. And I will now show you how the patient was treated. The patient arrived at the emergency room. I'm sorry that it's already 8 o'clock, but I assume that we can go a little past.
Thank you.
Thank you.
No problem.
At the emergency room, oral fluids and the medications were withheld. And keep in mind now that any medication that was creating antidiuresis is erased. So we are starting with the possibility that the water excreting defect will be reversed, and we have to keep our mind into autocorrection. They gave him some potassium orally. They continued the 0.9 sodium chloride that he was taking in the ambulance at 150 mL per hour. 1 hour from that time, we see a sodium of 102, and at 3 hours from presentation, he's transferred to the ICU where the sodium is now 102, and the intensivist decides to give the patient hypertonic saline at 75 mL per hour. We have a sodium concentration at 6 hours, which is a delta of 4. And then at 10 hours, the patient produces 850 mL of urine, but they don't tell us the composition of that urine. The K is 2.7. The patient is oriented ×3. They give him more potassium chloride, and they switch him now from 3% hypertonic into 0.9% sodium chloride and 40 of potassium. So the composition of the urine is 194 milliequivalents per liter, the composition of the infusate. At 20 hours, the serum sodium of the patient is 18, a delta of 18. The serum sodium is 119, but a delta of 18 at 20 hours. The patient had an over 4 liters of urine overnight. We don't know its composition. Look at the potassium and the creatinine. At 24 hours, where I have set a limit of 6, we don't have a delta sodium, but it was 18 at 20 hours. The patient now oriented ×3 is conversing appropriately. is given more KCl, is transferred to the floor, and they continue the 0.9 sodium chloride with 40 milliequivalents of potassium chloride. At 26 hours, at 44 hours, so almost at the end of a 2-day in the hospital, the delta sodium is 26. Almost 4 liters of urine is also put out. Look at the creatinine and the K. In 48 hours, the patient is oriented ×3 in conversing appropriately. Neurologically is declared intact, eating meals with assistance, and is going to be discharged in the morning, and treatment is continued. At 68 hours, there's a delta of sodium of 30, and the patient is being prepared to discharge. At 72 hours, 3 days from admission, the patient starts complaining of moderate weakness, is neurologically intact. The discharge was postponed, and then they plan a swallow test because she has difficulty swallowing, and the patient fails the swallowing test, becomes lethargic by 96 hours with a slurred speech, weak extremities, brain MRI is negative, and on follow-up, the patient is deteriorating, cannot move the extremities, cannot respond to stimuli, and on the 10th day from admission, he has extensive pontine and extrapontine myelinolysis. I want to reflect a little bit on that because the patient, as I described him, had to have a chronic hyponatremia by virtue of the sodium of 101. I cannot exclude an acute element on top of that. By virtue of the serum sodium, it had to have most of the hyponatremia being chronic. He had 3 solid factors for ODS, and he's been treated with hypertonic and sodium chloride while producing massive amounts of urine. The urine is not followed, so in all likelihood what was happening is he was being corrected through various routes, through the administration of hypertonic sodium and K, and through developing autocorrection by a hypotonic urine production. So I want to overemphasize that and say that I would not be bothered by somebody giving him a little bit of hypertonic for an hour or 2 and following what's happening. But I would have been very, very careful with the co-administration of potassium. And if I was managing the patient, because there is any urgent indication for treatment, I would have given him some potassium first, orally or intravenously. I would follow the urine very, very carefully. And then depending on the progress, I will be very, very quick into imposing actually hypotonic fluid infusion, potentially by co-administering DDAVP. So this is a very sad circumstance that should not happen, but it shows something that happens, unfortunately, not uncommonly in various situations, because the physiology of the way the kidney responds under these circumstances is not respected. Thank you very, very much for your attention. I will be glad to respond to questions or comments.
Oh, thank you. That is excellent presentation, Professor Madias. It's really excellent and practical, because we normally see these patients on our daily basis, but management, as you have clearly pointed out, is quite challenging and difficult.
Of course.
So, yeah, it's time for question and answers. And
questions in the chat, beginner. All questions are in the chat.
Yes, Professor Madias, I don't know your time, but we have so many questions here. Can you hear? I mean, I don't know your time, but can you read? I should read it for you. Yes, can you read the questions, please?
I cannot read the question for some reason.
Okay.
Again, so, you can read it. Again, can you read it?
Yes. Yeah, I can read it for you. Okay. So this is a question from Dr. Lloyd. How does one decide on the volume of free water consumption in the situation of fluid restriction? Dr. Madias.
I'm sorry, I didn't get it.
How does one decide on the volume of free water consumption in the situation of fluid restriction?
Oh, how much restriction to impose?
Yes.
Yes. I usually follow what's happening in the urine. And for a situation where the urine, we have published on that, the urine over plasma concentration of the urine electrolytes or plasma concentration is less than 1, I impose a mild restriction, let's say 1.5 liters or so. But if the urine electrolytes are greater than 1, so the amount of urine, sodium and potassium exceeds the plasma potassium, you can imagine that the urine becomes a situation of aggravating the hyponatremia. So I impose a severe restriction to less than a liter or so. So I use we have talked about this in our article, The Challenge of Hyponatremia. I use the urine to really guide me. And if the urine sodium and K is less than the plasma sodium, I impose a more lax restriction. If it is greater, I really will impose a severe restriction. Now, obviously, water restriction is an inhumane situation, and I'm always mindful of that. It's something that is very difficult to tolerate. And this was the excitement that I got when the V2 receptor antagonists like tolvaptan were developed, because in essence, it's a physiological treatment. It just deals with the root cause of the hyponatremia, as opposed to saying that, oh, I will restrict water to you so that, you know, if I restrict enough water through your insensible losses, you will correct at some point. You know, unfortunately, those drugs continue to be very, very expensive, and they have not really attained substantial utilization even at medical centers, although their physiology is quite appealing. So I'm very mindful of the situation of how the patient will feel if you impose a considerable fluid restriction.
Thank you, Professor. Though in our setting, especially in Africa, in Tanzania particularly, measuring urine sodium and potassium is, it's not routinely done in our setting, and it's difficult to measure. So we normally depend on serum sodium and potassium for the management of hyponatremia.
Yes. I see here. Please advise what condition you would consider 3% sodium chloride. As I said, this is for me a situation for severely symptomatic hyponatremia as I defined it. And the important point is that this is a very, very useful tool, but one has to know how to utilize it, keeping in mind that if it's utilized on the background of somebody who has already developed adaptation of their brain to hyponatremia, you run the risk of ODS, okay? So there is nothing wrong to using, 3% sodium chloride, even in situations that are not extreme. There is no the symptomatology is not necessarily extreme as I defined it, as long as you know what you are doing and you are following the patient's course. So this is not a medication that you use and then you say, I will see you in the morning. It's a medication that can be very, very, very dangerous if it's not used appropriately. But it can be life-saving, and many times I will use it, for a few hours, and I will say, okay, I project that I want to increase my sodium by 3. let me use it and then see what's happening, see if the situation of the urine production and composition has changed, and then change it appropriately. But I want to emphasize that these are not drugs that you use and then you say, I will see you in the morning. They're potentially very, very dangerous drugs as long as the brain has really gone through some type of substantial adaptation, because then you run, unfortunately, the risk of ODS.
Right. Thank you. Thank you very much. Another question is, yeah, what is the mechanism of hyponatremia in marathon runners, and how frequent is it, and how is it at risk? Who is at risk for this?
Yes. You know, initially, when the people had seen hyponatremia in marathon runners, they thought that it was a volume depletion situation, and that the patient, by drinking some hypotonic fluids, was expressing that. But then very careful studies that were done showed that, yes, this is a component of that, but overwhelmingly, most of the cases were not really volume depletion, but it was an antidiuretic state that was coming from the intensity of the effort, probably some, CNS factors that we don't really understand well, and a tendency to really impose a water excreting defect, and that the patient, the runner, by drinking water, was imposing a situation of retaining fluid, as opposed to a state of losses of sodium and then water retention secondary to that. So that the most common physiology appeared to be water retention posed by a water excreting defect through a stimulation of arginine vasopressin. So it was an SIAD physiology mostly, as opposed to a volume depletion physiology. As I said, those coexist, but most of the cases, studies have shown by experts in the field, that most of the situation is not a depletional hyponatremia, but is a situation of a SIADH situation, where you have increase of antidiuretic hormone coupled with a combination of some sodium loss, more than the usual SIAD, but water retention, as the athlete takes water intermittently. So it appears that, as I said, careful experiments where they weighed athletes showed that most of them had gain of weight at the end of the triathlon or the marathon, as opposed to having lost weight, and it was free water that they had accumulated.
Thank you. Thank you very much, Professor.
We have a Boston Marathon, and our hospital is along the route of the marathon. So every time we'll get several runners in our hospital. Some of them are milder, some of them can be serious. Thankfully, we have not really experienced any bad situation. In most of them, as you replete them, you will see that they do very, very well. But I have always advised the house staff that you never know that your patient was not hyponatremic to start with. And actually, there are such documented cases of patients with chronic hyponatremia then running in Boston Marathon, which suggests that there is very substantial brain adaptation. I say that because there are always calls, let's give them normal saline and discharge them in few hours. And I never do that, because I do not know that the whole situation is acute, and I would rather have them overnight for one night and then discharge them. Thankfully, we haven't had any bad consequence, despite scores of patients that come, because our hospital is along the route of the Boston Marathon.
Thank you, Professor. Thank you very much. One last question for the sake of time.
Please.
Why do not recommend Vactans in the setting of hypovolemic hyponatremia?
Oh, it's only because it doesn't really address the cause. I mean, in the setting of hypovolemic hyponatremia, you have lost effective circulating volume. So you have an arginine vasopressin that is there, that's stimulated, and you start concentrating your urine in an effort to somehow defend your decreased extracellular fluid volume. Obviously, the water which is retained is spread in the intracellular and extracellular compartment. Its effectiveness in terms of how much will be in the intravascular volume is obviously much less as compared to giving normal saline, but some of it will do it, and certainly is not that effective. So to the extent that you will use a vasopressin receptor antagonist in this circumstance, you will potentially make things worse because you don't really address the root cause of the problem. Okay, you have increased arginine vasopressin, which concentrates, so withholds some water, which has minor impact compared to administering the correct action, which is sodium chloride. So you correct minimally, but you don't really address the problem that you are having, which is a depletion of sodium chloride as the cause of generating the hyponatremia. So as you know, a loss of 10 to 15% of extracellular volume exerts a non-osmotic stimulation on arginine vasopressin release, which imposes the problem with urine concentration and the generation of hyponatremia. It's only if you replete the volume by administering sufficient sodium and water that you will erase this non-osmotic stimulus, and you will then go into a phase of dilute urine and you correct your hyponatremia. So you don't really do anything by using a V2 receptor antagonist. Actually, you will be losing more water into the urine and you will make things catastrophically worse.
Thank you very much. So I will allow only one comment from the panelists before we allow Dr. Madias, Professor Madias, to finish his presentation. Any comment from the panelists? I've seen Dr. Joseph Ntarindwa from Rwanda. You have a comment or question?
Thank you, Emin, and let me thank Professor Madias for he's brought out a lot of new things, and that has made me think that I'm old-fashioned. I will start with one question, although I have two questions. Now, question number one, in a few years back, I think there was this feeling that hyponatremia cannot be symptomatic if a patient has got a sodium concentration that is over 120, and therefore, if you're treating hyponatremia, the target was actually to reach 120, and then you can monitor after that to see whether you can, taking the patient beyond those symptomatic levels, and it was thought probably it would even minimize further, the risk of pontine myelinolysis. Now, in this patient, I could see you actually continued active treatment, even when the sodium concentration had gone up to 127. Now, is this teaching old-fashioned? I need to be updated on this. Now, second question is...
I think, if I understood it well, the question tries to make the point that there is not really a symptomatic hyponatremia. In the past, there were articles and articles written about chronic hyponatremia being asymptomatic. The asymptomatic chronic hyponatremia, that after studies were done and this kind of artificial time point of 48 hours was established that allows more or less brain volume adaptation. And, here you can have somebody who has a sodium of 120 and they feel fine, 125. But if it is acute, they can have a seizure and they have been, can be completely obtunded. So there was this marked realization that chronic hyponatremia, as I defined it, past, let's say, 48 hours, is so milder that we started calling it asymptomatic. But it took really careful observations after patients were sustaining falls and fractures and seeing that their serum sodiums were 128, they were 130, 127, and then they had major symptoms. So in essence, we went to the realization that there is no asymptomatic hyponatremia if you are careful enough. And actually, patients who were examined by neurologists and they were defined as completely normal with a detailed neurological examination were found that on careful testing, as with applying some, mild computer test to make some simple calculations, or trying to walk straight on a sensitive platform that sees whether you walk straight or you go zigzag and so on, have substantial symptomatology. And then they found that they have a tendency to fall and the patient to sustain fractures from those falls. All this thing brought to realization that there is no really asymptomatic hyponatremia, that there is some residual nausea, there is some headache, there is some ataxia, there is some cognitive difficulty. And I think the cognitive difficulty has not been promoted as much as I would have liked to, because I really have some concerns. And I say that with some hesitation because I have not proven that, but I have some concerns whether some patients with mild chronic hyponatremia, let's say sodiums of 127, 128, 29, 30, whether they should be driving. I have some concerns about whether this is appropriate, but this has not been examined by anyone. So the main point that I think, if I understood well, that our questionnaire posed was that there is essentially no asymptomatic hyponatremia. There is severely symptomatic, moderately symptomatic, mildly symptomatic, oligosymptomatic, but there is no asymptomatic hyponatremia if you examine that carefully. And this mildly, moderately symptomatic hyponatremia can be a harbinger of bad news if you don't pay attention to it and you treat in an overly aggressive way. I do realize that by imposing a limitation of 8 milliequivalents per any 24-hour to people with low ODS risk, or 6 milliequivalent per 24-hour, you might delay the discharge of a patient. On the other hand, I think that this is a reasonable price to pay if you are going to limit or decrease markedly the chance for having ODS in view of the devastating consequences of that. I don't know if I responded to the question, but
yeah, I
believe.
I think I got the message. I think now the take-home message is hyponatremia always calls for attention, whether it is about. I mean, the moment it is less than 135. Even if it is, above 120, I think that's a take-home message.
Yes, correct.
All right. Thank you, Professor Madias. I think you have come to an end of today's session. Very exciting session. Excellent presentation.
Thank you for the invitation. Hi, Lloyd.
Thank you very much.
Yes.
Thank you so much.
Thank you so much. Thank you so much, Professor Madias. Thank you so much.
It's a great pleasure.
There are so many people who have asked me now, They want just an hour of question and answers on hyponatremia. So not now. Sometime, Professor Madias, when you're free, whether we could have that, because it's the commonest electrolyte abnormality and a lot of confusion. So sometime later, whenever you have the time, we would love to have you back.
Thank you so much. Thank you. Great
So
to see you all.